This next video will review the most commonly seen secondary open-angle glaucomas.
This here is a reminder of all of our classifications of glaucoma. And even though there are a number of things on this chart, a reminder that the primary open-angle glaucomas are the most common of all the glaucoma that we're going to see. However, part of making the diagnosis of primary open-angle glaucoma is knowing how to rule out all of these other different kinds of glaucoma and understanding what we need to be looking for in order to help rule them out. So we're going to jump into talking about secondary open-angle glaucoma, and we're going to be focusing on some of the more common types of secondary open-angle glaucomas. The ones that are listed at the bottom of this list are a lot less common and a lot less likely to be seen in practice. All secondary open-angle glaucomas are associated with an ocular or systemic abnormality that causes an elevation in IOP. And it's this elevation in IOP that leads to glaucoma. The most common types that we're going to see in practice are pigment dispersion glaucoma, exfoliation glaucoma, and angle recession glaucoma. And so we're going to spend more time talking about these three. Pigment dispersion glaucoma starts as pigment dispersion syndrome. And pigment dispersion syndrome is characterized by the liberation of pigment from the iris pigment epithelium. The pigment is carried by aqueous humor convection currents and deposits on tissues in the anterior segment. So you're going to see pigment on the structures that it comes into contact with. So we see pigment on the corneal endothelium, pigment on the lens surface, and most importantly, pigment in the trabecular meshwork. The pigment granules accumulate in the trabecular meshwork, and this can lead to progressive trabecular dysfunction and eventually elevation of IOP. In the early stages of pigment dispersion syndrome, before we start to see an elevation in IOP, the trabecular meshwork is able to metabolize the pigment granules and clear them out of the trabecular meshwork so they don't cause a clogged drain. But once this stops being able to happen, once the trabecular meshwork no longer is able to get rid of the pigment that's accumulating at the same rate that it's being accumulated, we end up with an elevation in IOP. So the pathophysiology leads us to something called reverse pupillary block. And in reverse pupillary block, what ends up happening is there's an increase in pressure in the anterior chamber that causes a backwards bowing of the iris. And so one of the features that we see clinically in pigment dispersion syndrome is a concavity to the iris as it bows backwards. This causes the iris to rub on the zonules and release pigment, which is dispersed into the anterior chamber and eventually into the trabecular meshwork. So normally in pupillary block is a normal physiological way that the eye sits. We have the iris sitting gently on the lens. There's an opening space here that maintains a pressure gradient so that the fluid flows from the posterior part of the aqueous of the anterior chamber to the trabecular meshwork. And so the iris acts as a valve. But in these cases, we end up with one that the iris is a bit more concave and you get the rubbing of the zonules. So some clinical features are that the pigment is released during pupil mydriasis and exercise, which means that patients might complain about an increase in symptoms related to elevated IOP during times of pupil mydriasis and exercise. The iris becomes more concave during exercise, and so symptoms that are suggestive of an increased IOP include halos and glare around light, as well as nausea. Another clinical feature is that the pigment liberation lessens with time. So pigment dispersion syndrome can reverse and stop progressing. And this occurs in about 10% of the time. So what happens is we start to see a release of pigment from the endothelium and trabecular meshwork. And so you don't see the effects of pigment dispersion anymore. And what this might help to explain is individuals when they're older who no longer have pigment dispersion syndrome, who have features of glaucoma that is not progressing. And this would be the case if they had it at one point in their lifetime, never were seen for an eye exam, and then came in for eye exams later on in life. One thing that differentiates pigment dispersion from our other glaucomas is that it does occur earlier on. The typical feature of somebody that has pigment dispersion syndrome is a young male, often between the years of 20 and 40. It tends to be a bilateral but asymmetric condition, so it's not uncommon that we're going to see it more advanced in one eye than the other eye. It's more associated with myopia and lattice degeneration, and because of the lattice degeneration, there's a link between retinal detachments. And then in addition to this, there's a triad of clinical findings that we see in the anterior segment. A Krukenberg spindle, which is the accumulation of pigment on the corneal endothelium. And so what this typically looks like is a triangle with a thicker base and a pointy top to the pattern of it. This is a fairly prominent picture of a Krukenberg spindle, even though it might look difficult to see in this photo. These can be quite hard to see clinically. If you see any pigment on the endothelium, it's always a good idea to then check to see if there's any iris transillumination defects. And the iris transillumination defects that are going to be consistent with pigment dispersion syndrome are those that are located in the mid-periphery iris, so these ones here. And you might not see it as pronounced as you do here, but you're looking closely for that appearance. Then, if you have any pigment that you see on the anterior surface, and actually we're going to be doing gonio on all patients that we are suspicious of having glaucoma, regardless of whether we see anything here. But the third finding is a densely pigmented trabecular meshwork seen on gonioscopy. And one thing that you'll notice here is that where we see all of this pigment, it blocks the other structures within the angle. So we don't see all the 5 structures of the angle, even though it's wide open. And so oftentimes you're going to get this 360 around the cornea, around your angle. So it's going to be seen in all directions of all quadrants. So one other finding that's not necessarily part of the clinical triad, meaning that you may or you may not see this, is something called Scheisse stripe, which is pigment on the anterior lens surface. And so that's seen when you focus on the anterior lens and you can see a densely pigmented line. So something else to look at. So pigmentary glaucoma is essentially the progression of pigment dispersion syndrome to a optic neuropathy consistent with glaucoma. So we don't call it pigmentary glaucoma until we start to see damage to the optic nerve. So we can have pigment dispersion syndrome and an elevated IOP, but we still wouldn't call that glaucoma until we see the development of the optic neuropathy. You're going to see an IOP rise in glaucoma development in about 30 to 50% of individuals that have pigment dispersion syndrome, but even more common if you have the IOP rise. 10% chance of progression to pigmentary glaucoma over 5 years, and a 15% chance of progression over 10 years. So the longer they have it, and the longer they have, and especially an IOP rise, the more likely they're going to have glaucoma. So the management of pigmentary glaucoma isn't unlike what we've already talked about with primary open-angle glaucoma. One thing that you might read when you look at textbooks later on or here is that a penetrating iridotomy or an LPI may be helpful earlier on in the condition. And this was kind of old thinking, and the thought behind why it was helpful was that the iridotomy placed a hole at the peripheral part of the iris, which got rid of the concavity of the iris, so lifted the iris up off of the zonules. There's been a Cochrane review that was put out in 2016 that looked at the data for this and found that there wasn't really much supporting data that this is helpful earlier on. So it's not gold standard management to refer anybody that has pigment dispersion syndrome for an LPI, but you might hear that or come across that when you're out in clinic. The actual management once they have an elevated IOP is similar to primary open-angle glaucoma. Usually start with medical management, and then oftentimes these patients are going to need something more like a laser surgical management because of the fact that the intraocular pressure is a lot harder to manage. And so that's why our regulations within our profession usually discourage from optometry being the primary doctor or person following these patients with glaucoma, and we tend to do more co-management. So here's just an example of what the peripheral iridotomy would do. So here we have a concave iris from pigment dispersion syndrome, and then you put the laser beam in, and that straightens out that iris and it's no longer rubbing against these zonules here. So the next condition we'll talk about is exfoliation syndrome, classically known as pseudoexfoliation syndrome, although we've changed the nomenclature slightly because what they found is that it's not actually pseudo-exfoliative material that's causing the glaucoma, it's real exfoliative material, so it doesn't really make sense to keep the word pseudo in there. Exfoliation syndrome is the development of an abnormal production, deposition, and turnover of proteins that's produced by several ocular structures and tissues. But what causes a problem is when these proteins obstruct the trabecular meshwork, because that's going to decrease outflow and ultimately increase IOP. So similar to pigment dispersion, we have first an exfoliation syndrome that can exist without an elevated IOP, and then eventually it can progress to causing an elevated IOP and then a risk of developing glaucoma. So not everybody that has exfoliation syndrome is going to develop glaucoma, similar with pigment dispersion syndrome. The pathophysiology of exfoliation syndrome is that the exfoliative material is produced in the eye. It's not only produced in the eye, but the eye is the only structure that the production of this material is going to be cause pathology. So even though we get it in other structures of our body, it doesn't cause any issues anywhere else except for within the eye. So the exfoliative material is produced by the lens, corneal endothelium, the iris, vascular endothelial cells, ciliary epithelium, and the trabecular endothelium. And as I mentioned, it can be produced in other structures of the body, so it's also found in the heart, lung, liver, kidney, gallbladder, and in the brain. The reason that it causes a problem is because the material that's produced, this protein, deposits on ocular structures, and one of the structures is, of course, the trabecular meshwork. And so that can cause an elevated IOP. It's thought to also potentially be associated with a reduced ocular and systemic blood flow, and so there's also a perfusion issue that can be associated with this as well. The clinical findings that we see are shown here. And so what you'll see here are changes in the lens structure. So this is the iris, and this is a dilated pupil. This is where the iris normally sits when it's non-dilated. And so you can see a ring of pigment around here, and then the more dilated they are, you can see the exfoliative material further out. So this is kind of our pathognomonic sign of exfoliation material, but you're only going to see it in a dilated pupil. And so we have to dilate all of our elderly patients that we're suspecting might have glaucoma, and even a good idea to obviously dilate all elderly patients so that we can see signs like this that aren't evident without dilation. In gonioscopy, what we end up seeing on exfoliation syndrome is a mixture of clumpy trabecular meshwork pigment. So we don't see the gray protein material that's consistent with exfoliative material. It's not as obvious in the gonioscopy or in the angle as it is on the lens surface. What we'll see instead is pigment, but it's a different pigment appearance than with pigment dispersion syndrome because of the fact that you end up with clumpy pigment. And the reason for that is the protein material that also gets accumulated is sticky. And so the pigment's going to stick to the areas that exfoliative material is. So we see a clumpy trabecular meshwork appearance. Other findings are you might see some of these dandruff flakes deposited in other ocular structures such as the endothelium and the trabecular meshwork, the iris, the pupillary margin. We're not going to really be looking at zonules. Then the other finding that's consistent with exfoliation material is this transillumination that occurs around the pupillary ruff. So that differentiates it from pigment dispersion syndrome, which again is the mid-peripheral iris. And then we can also see pigment on the corneal endothelium, trabecular meshwork, and the iris in this condition as well. So something that we want to be looking at, looking for in exfoliation material is pigment. So one of the main features of exfoliation syndrome that's important to keep in mind is that it does develop in the same age group that we would expect to see primary open-angle glaucoma. And so it's not uncommon for exfoliation glaucoma to be misdiagnosed as primary open-angle glaucoma if gonioscopy or other features go missed, or dilation or what have you. If that's not done, the signs can go missed. And the reason that this is a problem is because exfoliation glaucoma tends to be a much faster progressing glaucoma. If you remember that slide I showed right at the beginning of the course, it's a much faster progressive glaucoma and needs to be treated more aggressively. So we don't want to miss exfoliation glaucoma. It usually starts unilateral and then it may become bilateral. Oftentimes we just see signs unilateral. We might not see the signs bilaterally, but we can kind of assume that if one eye has it, that the other eye might be at a risk of getting it as well. And then of course the main issue is that this can lead to an elevation in IOP once the exfoliative material blocks the trabecular meshwork. It used to be thought that exfoliation glaucoma was unique to Caucasians and Scandinavian populations, but it actually can occur in any nationality. So it's not pinpointed to just Caucasian and Scandinavians. We want to look for it in all backgrounds. It's more common in women, but the combination, once glaucoma develops, is the same in both men and women. So more women are going to have the syndrome, but then equally the same amount of men and women will have glaucoma. There's some associations with other systemic associations that might be related to exfoliation syndrome, such as transient ischemic attacks, stroke, myocardial infection, cerebrovascular insufficiency, Alzheimer's, and hearing loss. These aren't strong associations yet, which is why we still consider exfoliation syndrome in mainly an eye disease, but there's more and more evidence coming out that we might see that shift a little bit in the next few years. So exfoliation glaucoma occurs once we have that increase in IOP, and once that increase in IOP causes damage to the optic nerve. So about 25% of patients with exfoliation syndrome are going to develop an elevated IOP, and then 1/3 of these will develop glaucoma. Patients with exfoliation syndrome are twice as likely to convert from ocular hypertension to glaucoma. And then when the glaucoma is present, they're much more likely to progress. And of all of the open-angle glaucomas worldwide, exfoliation syndrome accounts for about 25%. So it's a fairly big chunk of people that have it. So complications of exfoliation syndrome, we talked about open-angle glaucoma, or we are talking about open-angle glaucoma as being one, but there's also other risks as well, and this is why it's important that we don't miss exfoliation syndrome. For one, it can make cataract extraction more difficult because it loosens the zonules. It can also accelerate the formation of cataracts. And there's a component of patients that have exfoliation syndrome that will end up with narrow angles and a greater pupillary block effect. So it could potentially turn into a narrow angle glaucoma and not just a secondary open angle glaucoma. So management is a little more complicated in these patients as compared to primary open angle glaucoma because it tends to be more of an aggressive and unpredictable disease. And this is because of the fluctuation in IOP that happens consistently throughout the day. So typically in earlier stages of the disease, in somebody that has a more controlled IOP, management is similar to primary open angle glaucoma, especially before we start to see any significant rise in IOP or any changes to the optic nerve. Aqueous suppressants are thought to potentially work a little bit better because of the fact that we're dealing with a glaucoma that is from an obstructed outflow. So if we improve outflow, or we're using a medication that's meant to improve outflow, it's not going to necessarily work as well because the outflow channel or pathway is already damaged. So the thought is start with something that's going to bring down the actual production of aqueous humor first. Laser can be considered, but most of these patients will end up needing surgical management once they get into the more aggressive form of glaucoma and IOP. Okay, so glaucoma can occur due to trauma. The type of glaucoma that we're going to see more commonly in practice is late onset glaucoma from trauma. These groups of glaucoma, when it's related to trauma, is unilateral, and it's one of the only types of glaucoma that is unilateral because it's developing in response to trauma in the eye. So in early onset, you can get glaucoma, but again, these aren't the ones that we typically see in practice because usually they're in the emergency room and go off to the ophthalmologist, but you can get blunt injury causing early onset glaucoma, and this occurs from inflammation, which leads to inflammatory cells clogging the trabecular meshwork, hyphema, which leads to red blood cells accumulating in the trabecular meshwork, or trabecular meshwork contusion, which causes significant damage to the trabecular meshwork, also reducing outflow of aqueous humor through the trabecular meshwork. Penetrating injury and chemical burns can also cause an obstruction to outflow as well. The type of glaucoma that we're going to see more often in clinic is from a late injury, and these often tend to be unilateral, and this is from angle recession, which is the separation between the longitudinal and circular muscle fibers of the ciliary body, so trauma that causes this separation. About 4 to 10% of patients that have angle recession greater than 180 degrees within the trabecular meshwork will go on to develop glaucoma years later. Some signs of angle recession include a broad ciliary band when you're looking at gonioscopy, localized depression, and torn irises. And then what will happen is because of this separation that happened a long time ago from trauma, you end up with scarring that occurs within the angle, and that's going to create an obstruction to outflow. What's interesting is that these patients that have angle recession that go on to develop glaucoma will develop glaucoma in the fellow eye up to 50% of the time years later. So it's thought that this development of glaucoma that's precipitated by angle recession at the onset is more likely to happen in somebody that was likely to have gotten glaucoma anyway, just later down the line. And so that's shown by the development of glaucoma in the fellow eye. So if you see angle recession and you have angle recession glaucoma in one eye, it's important to pay attention to the other eye because they are at higher risk of getting glaucoma in the other eye. And in that case, it would just be a regular primary open angle glaucoma. So this is what you end up seeing. This here is the depth of the ciliary body, followed by your scleral spur and trabecular meshwork on top, and then Schwabe's line up here. So normally our ciliary body is going to be, the width of that one red line, but you can see here that the width of the ciliary body is almost 2 times the width of the rest of the angle. And so that's consistent with what we expect to see in angle recession. Oftentimes people ask why, when we look at it, you might expect that this would improve outflow. Do we end up with glaucoma down the line? And the reason for that is because over time, what we end up getting is scar tissue within the trabecular meshwork. So this injury has been long-standing, and then with time we get scar tissue building up in the angle, and that causes the restriction to outflow. So here is a summary of some of the other open-angle glaucomas that can occur. Again, we don't have a ton of time to go into all of them, and I'm not going to test you on the ones that we didn't get to go through, but it just gives a nice kind of background on what you could be looking for.